Good morning. Thank you for having me. Unfortunately, my talk that I put together was done on a Mac, and it's not pulling it up on this PC. So you're going to see my slides from a previous talk that I gave here. Unfortunately, not my talk that I did on a Mac. But I actually had my first slide that I wanted to share and share with Eric, but he's walked out apparently. But is a picture of my office. He left? Yeah. All right. Well, I'll have to share it with him personally, but I wanted to, in homage to Eric, has been a mentor to me since 1996. And in a picture in my office is actually a picture of Eric Klein and me operating together when I trained with him. And he's been a mentor and a friend in all aspects of life. And I just wanted to mention it as he's kind of moving on to a next part of his career, and I'm looking forward to watching and being mentored by him as he enters into that next phase. So I'm very excited for him and appreciative of what he's done for our community and all the people he's trained. So we're very lucky to have someone like him in our community. All right, I'm going to do the best that I can with the slides that from a previous talk, so I apologize. I don't need to tell you guys, but prostate cancer is common. You can debate whether it's 1 in 6, 1 in 7, whatever it is. It's a very common disease, and we have a whole spectrum of people who are affected by it, from people who, as you know, are on active surveillance and close monitoring to disease that's gotten outside the prostate. So certainly a real issue. I'm going to talk a little bit about some of the advances really in imaging of prostate and kind of a 30,000-foot view of kind of what we are seeing in the change in prostate cancer. I can walk, right? I don't have to be stuck to this microphone. So we're going to see a change. Can you guys hear me? Tell me if you can't hear me. We're going to talk a little bit about what we've seen as the change. And so this was a few months before I was born. But this was the New York Times headlines when we first had man walk on the moon. And you can see, actually, what I want to point out is the size of the font. It was pretty important. And in news, when things are important and dramatic, they make them bigger, right? So this is on the headlines of the Urology Times a number of years ago, bigger than man walking on moon, talking about MRI and guiding prostate diagnosis. And I can tell you, before we started having really the integration of MRI routinely into our practice, when people ask me what's the biggest innovation in prostate cancer, prior to this, in my opinion, it was active surveillance. The idea that we can monitor a cancer, which seems crazy because we all fear the word cancer. We almost get a cold sweat when we hear it. And I understand why, but as we say, not all cancers are the same. And active surveillance was really a major change in the way we can manage cancer. And we're doing that with other cancers now as well. But in my opinion, the introduction of MRI, even in the early diagnosis of prostate cancer, was a major change. And we'll talk a little bit about that. I don't have to tell this group about what's involved in the diagnosis of prostate cancer. Certainly using the transrectal biopsy. I believe that in the next 10 years, we're going to think this is the most archaic way of diagnosing a disease. It seems asinine to me that in today's age, we are having an elevated number that we are telling you all the majority of time when your PSA is elevated, there isn't cancer. And then we stick a probe in your rear end and we take random biopsies of locations in your prostate where we think cancer might show up. It seems like in today's age we should be able to do better. And I think we are starting to see some major changes in this space. But I do believe that future generations of urologists are going to look back at how we diagnose prostate cancer in years past as just cruel and unusual punishment. So I think that is an outdated way. So what's the future? Certainly MRI in the diagnosis has really turned the lights on, if you would. And I'm going to show you a few examples. Now, you don't need to be a radiologist or a urologist to look at this image and see this is an MRI of a prostate, and you can see there's a black spot here. Okay? We weren't using this a number of years ago. So what we were doing is just taking biopsies of this location, which is called the peripheral zone of the prostate, which is where we know prostate typically, not 100%, but typically shows up. So we take random biopsies of this location. But once in a while we see, even up to 40% of the time, patients will develop prostate cancer in locations that we weren't typically sampling. And this is called the anterior portion of the prostate. So it is not uncommon, and I'll have a slide to show you a real patient. Patients were having 2, 3, 4 biopsies because we were very suspicious there could be cancer. And their biopsies were coming back negative. And oftentimes it was because they were in locations we weren't typically biopsying. When you get imaging and you can see the abnormality, all of a sudden it's like walking around in a room with the lights on. It makes a big difference. This is a quote from a friend of mine who's the chair of radiology at University of Michigan, used to be at University Hospitals, Vikas Gulani. And he says every time we need to do a biopsy, it means our imaging hasn't been good enough. So every biopsy, he considers every time we have to do a biopsy of anything, it's because we failed in imaging. Ideally, we should be able to diagnose eventually everything with just imaging. So this is kind of how we were doing prostate biopsies in years past prior to MRI, but I think that the MRI has improved us. So this was real animation here of what really could happen. Here are a couple different options. Patient has an elevated PSA, we do the standard biopsies, and the needle just misses the area of the cancer, this being the cancer. Or we can do that random biopsy and might pick up an area of insignificant cancer while there's significant cancer somewhere else. Or maybe it just goes right next to the area of cancer but misses the real hot spot area. So these are things that really happen. And I think these are things that were happening in people where we found that without direct targeting, we were missing, we thought we were finding cancer, and we would say to patients, you have low risk disease, but without appropriate imaging, were we really hitting the right area? So Eric talked a little bit about some of these, but you guys know a lot of this, that here's the tools that we currently have to diagnose prostate cancer. There are certainly other things coming down the pike. Eric talked about liquid biopsy, iso-PSA, things that are being evaluated, but nothing is the home run yet. It's a combination of these tools. And I would add that I think that multiparametric MRI, we really believe, and now it's starting to be added to the NCCN guidelines, really should be part of the evaluation of prostate cancer. I think if patients come in, we get in our practice, get an MRI before almost every prostate biopsy. So this just talks a little bit, and this is just talks about some of the things. This is from a talk I gave to physicians when I'm trying to convince them that we should be updating ourselves, and talks a lot about some of the different things we're doing in the surgical field. And again, I apologize, this is another talk. But basically, in the 80s, we were doing a lot of things that we don't do anymore, right? So it used to be that everyone who thought that whenever you went to the hospital and they thought you may have an appendicitis, they operated on you. We don't do that anymore. If we weren't sure what was going on in patients, we would open up their belly and look inside. It's called an exploratory laparotomy. We weren't sure. You were hurting, we weren't sure what's going on. We make a big incision, look around inside. It's called exploratory laparotomy. We never do that. We have imaging to help us with that. This just talks some of the specifics of MRI. But let me just show you a couple images of MRI and show you what I'm talking about. This is an MRI of the prostate. This white area is, again, called the peripheral zone, and this is where prostate cancer typically shows up. And this is a normal prostate. You can see it really nicely here, this white area. That's a normal prostate, no cancer. But I think those of you can see, hopefully it projects okay, you can see in the back of the room, when you get an MRI, you don't have to be, again, a radiologist or urologist to see an abnormality that could show up that is not yet diagnostic of prostate cancer, but highly suspicious. We have not quite yet, and I'm going to show you some data, the stuff we're working on. It's not quite diagnostic of prostate cancer, but highly suspicious. Again, this is an anterior tuber. These are the ones that concern me because without imaging, we would not identify these. We can see in this, I don't know if this projects well, but you can see sometimes when it's even bulging outside the prostate. And that's really important for us because that helps us guide treatment, whether it's surgery or radiation. That helps us guide how we want to treat these patients. You may have heard, if you've heard me talk, or you may have read about, if you follow kind of developments in prostate cancer, something called MRI fingerprinting. This was developed with a number of my colleagues, not me, but I've been lucky enough to be friends with them, from radiology and biomedical engineering at Case, called MRI fingerprinting. And fingerprinting makes sense to us. I think it's a great term because it's relatable to the lay people, where we understand what fingerprinting is, right? You put your fingerprint on something, you can look at the fingerprint and help identify somebody. Well, the idea of an MRI fingerprint is that everyone's MRI is very specific, and it may be specific actually to prostate cancer, right? So if you take a fingerprint, you can search a database, identify an individual, and find that match. And then you can find information about that person or that individual based on the match. Well, we can now, with MRF or MRI fingerprinting, do similar things and help in the difficult situations in identifying patients with their MRI findings. And this is a study we've actually published that basically, sometimes when people show graphs, I never really know what to look at, so I'm going to point it out for you. But bottom line is you see these two bars and you see these bars. These are normal, non-cancerous prostates. These are patients with prostate cancer. And you can see there's a clear separation. And this is basically patients who had MRI fingerprinting. And we were able to identify which patients with just MRI fingerprinting, which patients had prostate cancer and which ones did not. So you can see what I'm talking about is, Eric talked about these liquid biopsies, but the question is, are we also going to have the opportunity to use imaging, advanced imaging in the future to make the diagnosis and more accurately diagnose what's going on with diagnosing prostate cancer, detecting at an earlier and earlier stage if there's cancer elsewhere and where is it. So this is a study, another study that we published looking at MRI fingerprinting, and we looked at patients differentiating inflammation, which is our biggest problem, is that when we get an MRI, sometimes inflammation can look like cancer on those images I told you, those black spots. But this was interesting because if you look at the separation here, this group of patients had all similar MRI fingerprinting characteristics, and none of them had cancer. So if you look, here, again, going down here, this group, the blue triangles had inflammation, and the orange circles all had cancer. So down in this area, all the patients had prostate cancer. This area we still need to work on to try to differentiate the inflammation from the cancer. So these are some of the things we're working on. We have an NIH grant to try to differentiate that, because ideally what we'd like to do is use these technologies to diagnose prostate cancer. One of the other things that we're doing is working with our colleagues in biomedical engineering. A great friend and colleague of mine, Anant Matabushi, is doing some elegant work. And basically what they're doing is we take prostate cancer, and we take a prostate that has had identified cancer in it. And this is actually a real slide from a patient. It's a slice, like a slice of bread. And we look at it under the microscope, and there's a microscope image of a patient with prostate cancer. And here you can see is an area of prostate cancer. And so we can actually go with our pathologist and outline with a marking pen on the pathology slide where there's cancer, where there's inflammation, and where there's normal prostate. And we do this hundreds of times, thousands of times. And we enter it in a computer with the patient's MRI. And we can line up the exact slice on the MRI with the exact slice in the prostate in patients we've taken out prostates on who have cancer. And we enter it in the computer 1 time, 20 times, 500 times, 2,000 times. And you've heard about artificial intelligence, and it's very complicated. My son understands it perfectly. I understand it enough to be dangerous, but enough to say that the computers learn. And the computers learn pattern recognition on things that you and I won't necessarily see with our eye. And they can learn this so that all of a sudden you've told the computer 1,000, 2,000 times, here's cancer, here's the MRI, looks like a black spot, but it can look deeper. And it can learn pattern recognition. So eventually we can just show them the MRI, and the computer can identify where there's cancer for it. So you're starting to see that we are developing new ways to identify ways that we can identify prostate cancer. And this is some of the work that we've done, looking at mapping the prostate cancer to imaging to identify cancer with just the computer without doing any biopsy at all. And that's just, I'm going to skip through this because it gets into the technical stuff. But it can then develop, and this is again, on a patient who's not had a biopsy, but using the database of imaging that we are building. This is an MRI. We give it to the computer, and the computer can tell us we're concerned that there's an area of prostate cancer up in this region. And then we can develop true mapping that can then help us with more accurate diagnosis, and we can, I don't think this will play, it's a nice little video, but bottom line is you can understand that we're using new technology in helping diagnosis. So this is an actual real case of a 55-year-old gentleman. His PSA was 23. It was rechecked. It came back at 10.8, no family history of prostate cancer. You can see this is a gentleman who may have had a biopsy in the normal location and could easily be missed. But with an MRI, we found this dark area. You can see this area up here. And we targeted biopsy there, and he had Gleason 9 prostate cancer and 40% of one core, so certainly high-risk disease that could have easily been missed had we not done imaging. We talked about the ability to identify extracapsular extension outside the prostate, and if we don't identify this, this can certainly affect how we treat patients. Whether this patient is a good candidate for surgery, is this individual a good candidate for nerve-sparing prostate? Even tiny little lesions that can be identified that could easily be missed. This is right at the neurovascular bundle. So for those of you who may have talked about having prostate surgery, if we try to do nerve sparing, this is a patient that we absolutely would not want to do nerve sparing on. The cancer is right at the neurovascular bundle. This is a patient who does not have cancer. This guy just has BPH. And you can see this is a large prostate, but know those white areas I showed you on the prior MRIs? That white area is really thin and squished down here. You can see this white area. That's that peripheral zone. This is all the BPH. This is that peripheral zone where cancer typically shows up. There's no cancer here, but this patient may have a very high PSA because he's got a lot of prostate gland, but not necessarily cancer. This is another case of a 67-year-old gentleman whose PSA kept rising. Over 3 to 4 years, the PSA went from 10 to 20 to 50. He had 4 biopsies. 4 biopsies. They all came back negative. Not until we got imaging were we able to do a targeted biopsy. Again, you can see in this anterior lesion, this upper part of the prostate, we were able to identify using targeted biopsies and identify this guy had Gleason 8 prostate cancer, but all the other areas, the standard locations we normally biopsy, were all negative. So we're doing most of the biopsies now we're doing, if a patient has any abnormality on their MRI, we're doing directed targeted biopsies using fusion technologies, and I think this is going to only get better in the future. When we can actually do targeted biopsies in the MRI. So once in a while, if we don't think we can do as accurate biopsies in the office with a fusion biopsy or in the operating room, we can actually go into the MRI suite and do a directed biopsy. And this is an actual case where we can actually see the MRI and we can see the needle. This is the needle here under MRI guidance and an anterior tumor on that location that's often missed. We can see the needle going directly into the area. So as you see, we're getting more and more information from these MRIs. It tells us a story. It gives us more and more information. And Eric talked about the liquid biopsy. That's just the beginning of the story that it's telling us. But what if, for those of you who remember black and white TV, the snow? We look at this and this doesn't show us anything. This could often be like an MRI that is, we look at and we say, well, maybe we don't see much. We're not really sure what's in there. But what if we can dive deeper? What if there's information in here, but we can't recognize it with our eyes? What if we zoom in? Well, okay. What if we zoom in more and we see these dots? But what if there's information in these dots that we don't know the information that exists? But there's information in there, we just weren't smart enough to figure out what the information is. We're seeing these MRI and CAT scan images, but we're now learning there's a huge amount of information about each of us. Our disease, the cancer, the aggressiveness of the cancer. We just weren't ready to identify, we didn't know how to identify the information in these dots. But what if we zoom in beyond these dots and find out there's real information there? And when we zoom in further, we can find out very specific information about what's in those dots. And that's what we're starting to realize. And that's what we're starting to get, that we believe that we're going to be able to start getting very specific information on diagnosis, We're going to be able to get specific information about the cancer, about is this a cancer that needs to be treated or doesn't need to be treated? Is this a disease in which this patient is at a very high risk of metastatic disease? So we're excited by the future of what we're starting to see in this imaging. So I think we need to pull our heads out of the sand, not be afraid of technology, not be afraid to continue to push the envelope and look at what we can be doing. So I think that these images are really moving us in the direction of what I consider a virtual biopsy. I think that eventually in the next 5 to 10 years we probably won't need to do prostate biopsies. I know most of you are not upset about that. But I think that's where we're moving. I think that's the direction we're heading. And I think that we need to continue to evaluate this and look at these technologies. So I'm going to show you a couple different cases. This is a gentleman who was 63 years old. He had a PSA of 5.7 initially when he was diagnosed. This came to us from the outside. I don't have any information whether it was a 3+4 or 4+3. But in an outside place, he had a robotic prostatectomy and bilateral pelvic lymph node dissection in 2010. And he had 4+3 with some tertiaries, some degree of Gleason 5 in the specimen. And then about a year later, his PSA was undetectable. But 6 years later, his PSA became detectable, and then 2 years after that, it was rising. And he didn't really follow up very well with his urologist. So what do you do with this? Does this patient have disease outside the prostate? You know, we weren't always sure. And I had a slide in here, which unfortunately didn't make it to the current version of this talk. But actually, if you look at the number of cells, right? So if you think about prostate cancer, and patients often are concerned and say, well, if you've taken out my prostate, how could I ever? Why would you even need to follow me? If you've taken it out, there shouldn't be any cancer. But cells can get outside the prostate. And our only way to detect that on imaging is if we can see a mass. But do you know how many cells generally we need to be able to see a 1 centimeter mass? How many of you, take a guess, someone take a guess. How many cells are approximately in a 1 centimeter mass to be able to see it on a CAT scan or MRI? About 1 billion cells. About 1 billion cells. I had a slide showing that. That you typically if you have 1 cell, it could take up to 10 years until you see 1 billion cells that's detectable on a CAT scan and MRI. Luckily, we use PSA, which will give off, so if PSA is undetectable, we use that as a indicator as well. But our imaging is not perfect. Ideally, we would be able to have imaging that detected that 1 cell. Ideally, we would have imaging that detected not only that 1 cell, but where is that 1 cell? So we can target it and treat it. So this was a patient who had a type of PET scan, the Acumen scan, and we saw something lighting up right where the seminal vesicle was. So I sent it to our colleagues in radiation oncology, and the patient had salvage radiation therapy, and he's done very well, and his PSA has remained very low, not going up any further. But I think this is an example where imaging makes a real difference. And I think you're going to start hearing some trends, and my partner in crime, Dr. Spratt, is going to talk about where we are today. We mentioned the PSMA. This is a patient who was 67 years old, had a Gleason 3+4 prostate cancer, not a very high PSA, 3.3. He had cryoablation. We're not doing cryoablation currently at our place right now, but in 2010, an individual did cryoablation. Initially, his PSA was pretty low. But his bone scan was negative. He had this prostacy scan that isn't really used much anymore. And then he had an MRI, which demonstrated this large mass that wasn't identified prior to his cryoablation. So ideally was not a great candidate for cryoablation. Had he had that imaging, may have been identified. Tried salvage cryoablation. That didn't work. But then with additional imaging, a different type of PET scan, we were able to identify there was an area near the prostate where there was still active disease, and he had was given hormones, and then additionally was given salvage radiation and was well treated. But you can see here, with the appropriate imaging, we can identify where the disease is. I think that we're starting to see that imaging is playing a real role not only in the diagnosis, but more exciting, beyond just diagnosis, is in sometimes the more advanced disease, going after these cells, right? And in my opinion, the future is not looking for the billion cells, it's looking for the one cell, right? Because if we can identify that one cell, that's what's going to make the change. And I think you're going to hear a little bit about the PSMA, which in my opinion, I told you that I thought active surveillance was a major change in the way we manage prostate cancer. I thought the MRI was probably the next greatest thing. I think PSMA is really going to be the future, for the foreseeable future. And I have no question, in 5 years, the next young whippersnapper coming to talk to you here, I don't think it'll be me, but who knows, we'll talk to you about the next generation. And right now, I would say on the horizon, PSMA is something that we're excited about. I think not only will it help us in our diagnosis, but I think it's also going to help us target therapeutics to go after those 2 cells, those 10 cells, and still achieve a cure. And we're in a situation today it would be very hard for us to not only see it, but target it. So I hopefully have kind of just spurred your interest and excitement about where we are going with imaging, that there is absolutely advancements. And a lot of times when we've talked about advancements, they're in the area of diagnosis. But I think now we're starting to see advancements not only in the diagnosis, but in image-guided therapeutics. So with that, I'm going to introduce the newest prostate member to your community. It was important to me that Dan Spratt, who is the new chair of radiation oncology, came to this meeting. Unfortunately, this meeting was put together before he was even in Cleveland. Dan comes to us from University of Michigan as a chair of radiation oncology at University Hospitals. If he was, I'm going to pretend he's not sitting here because I don't want to say nice things about him in front of his face because he's a good friend, and I can't say nice things about a good friend in front of him, but he is really the future. He is a superstar. We are lucky, truly lucky to have him in our community. He is pushing the envelope. He is, as my patients who I send to him, I tell them to tell Dr. Spratt I'm much better looking than him, and he responds, well, he's much smarter than me, which is probably true. So I'm excited for you guys to get to meet Dr. Spratt. You're going to be hearing a lot about him. You're going to be hearing from him. He is really changing the direction of prostate cancer and doing some very, very exciting stuff. Dan.
Thank you.
Can you check this one?
All right, thank you so much. Very, very kind introduction. I always say, Lee's the better looking one. I'll be the brains. He can be the beauty. It truly, this is exactly why I do what I do, is things like this. And I'm ran over here in the Brown Stadium where we actually have our whole cancer center team together because we need to make our cancer center better. And so these are the days that I look forward to. So as Lee said, I'm a radiation oncologist, but more importantly, I'm someone that is obsessed, probably is the word, with prostate cancer, trying to take care of patients and their families. And so this talk has nothing to do with me telling you anything really about radiation therapy, but going to even beyond what Lee just talked about, especially regarding MRI and where we're moving. So anyone who's been diagnosed or knows someone with prostate cancer, we say know your numbers. Sometimes men read that, know your numbers, and we talk about PSA, the blood test, your grade of your cancer, your Gleason grade, or your stage of your cancer, is it confined to just the prostate or extending out? But there's a lot of, we call it heterogeneity differences for each individual man. I've seen patients with PSAs over 14,000. I've seen guys with PSAs, undetectable. The Gleason system, there's 9 different combinations of a Gleason score, and our current version of T staging, where the tumor is, there's about 9 choices, and that's over 1,000 different, even if you just simplified PSA to like 9 to 10 buckets, that's over 1,000 different combinations of this. So we can't, and we definitely no longer, especially after what you just heard, can no longer treat prostate cancer as just one entity. Really, you need a personalized approach. And so one of the issues is the way, one of the biggest factors that guides the way men are treated is this grade of their cancer. And while if you're focusing just on prostate cancer, that may make sense, but almost no other cancer in the human body could you, just by the grade of it, go from no treatment all the way to getting radiation, hormone therapy, potentially chemotherapy, just by changing that one score. but we put a lot of stock in this, and so we better be right. So are we always, if I took 10 pathologists and said, do we always agree on the Gleason grade? Amongst general pathologists, it's like 60 to 70% agreement, and even amongst experts, it's maybe 85% agreement. Kind of scary. But fundamentally, they're just looking at patterns. It's not a binary black-white. They're looking at little patterns to see, is this a Gleason grade 3, 4, 5, etc. So it's subjective. But where things are moving, and this isn't just a pipe dream, there's actually people using this today in parts of the world, and there's multiple companies, Google is one of them, that are now in this space, that just like with MRI, where it's trying to see things that are not human interpretable, there is now a great deal of work going into, and we do this here at UH, and many places do, where we digitize our slides. So you get your biopsy, which no one likes. You get a slide, if you remember those little glass slides. But now we digitize them, and thanks to artificial intelligence, we're getting to the point of where, number one, it's more accurate to tell patients do they have or not have cancer. Humans, we create errors, unfortunately. If you had 30 to 50 slides in front of you, and you're looking at these slides all day long, there's a chance you could miss a tiny little area of cancer. But this is the benefit of, we call it machine learning and artificial intelligence, and furthermore, they've shown that with this technology, it's about 99% accurate at calling the appropriate Gleason score. So this is something that is, I would say, emerging, and very soon, I think in 2022, you will see, and there's multiple of these companies that have already gotten what we call FDA breakthrough designation, and these will be used much more frequently. Whereas some people will say, look, I want to send my slides to Johns Hopkins or find that one person to read them. This is going to obviate that. The other thing, and this is really what Lee was talking about, is the way throughout history, right, we've diagnosed how extensive the tumor is. Still, if you look at our staging manual that all the physicians have to memorize, it's the rectal exam. And that is, pun intended, a crappy test, because I'm telling you, you have to have on average a 9-centimeter index finger to even feel the whole prostate. So many practitioners don't have that. And if you look at what MRI can do, not only does it provide these pretty pictures, you can now also, a lot of the technology Lee was saying, it can use this technology, this artificial intelligence, to start telling us characteristics about that tumor. You can also, in my world as a radiation oncologist, it used to be 30 years ago, they just basically put beams on and shot and blasted right through you. They hit everything in between. Guys had rectal bleeding and bladder issues. Now it's much more sophisticated where we're trying to carve and bend the radiation, but if you can actually find where the aggressive tumor is, computational power, supercomputing can actually target the dose to these areas to try to even further reduce dose to your healthy tissues. And there's other technologies that can ablate these types of tumors. And something that's still every day, probably I would say the most common test ordered, even probably more than MRI throughout the world for prostate cancer, is called a bone scan. And this is not intentionally a bad image. This is just what it looks like. And so the joke often amongst physicians is, a bone scan falls under the Department of Nuclear Medicine, and people call it unclear medicine because that's about as low resolution as you could imagine, but it's a technetium, it's a SPECT scan. But this is how we're telling patients, do you have cancer that has spread to your bones or not? It's not very reassuring, because even if I got, if Lee checked me and cracked a rib, it's going to light up on there. It's nothing to do with cancer. But what we have now, and this again, this is real. This is here today. It is FDA approved nationwide. And I'll tell you more about what PSMA PET is. But you tell me which one you're going to have more confidence in telling you have cancer that is confined to your prostate, or if it's spread somewhere. And so this is a PET CT scan, and so the CT scan helps you see all the bones. This is, right here we call it a sagittal. It's looking at a patient from the side. You can see all the bones of their spine, their vertebra, and areas that light up right there at the bottom of his spine, you know, that is area that there's cancer involved in. So what is PSMA, right? You already have to memorize PSA. You got all these acronyms. You know, it's prostate specific membrane antigen. And really what that is if you think of any cell in your body, think of it as a disc or a circle. The outside of a cell is its membrane, and there happens to be a protein that sits right through the membrane of a prostate cancer cell. We can now, people have figured out ways to target that molecule and attach things to it. So we have imaging agents that will lock on to those cells and light them up so we can see it, like in that last scan. We now have therapy. Probably in early 2022, you're going to see a big FDA approval for a radiation targeting. It's called lutetium PSMA. You inject it, and it hones to these cancer cells and emits radiation locally. That's for men with metastatic or advanced prostate cancer, but it's a game changer. And there's also a lot more. People are attaching other payloads to it. Some things, even vaccines, immunotherapy, drugs. These are all now possible because we never had something specific enough to where it wasn't just going to harm your normal tissue, right? The whole thing with chemotherapy is it attacks cancer more than healthy tissue just because cancer tends to grow faster, but it still hits all your normal tissue. So this is very exciting. And so what, you know, because PET scans are not the routine. Less than 1% of men worldwide with prostate cancer ever get a PET scan. It's just not part of our practice because most PET scans, if you talk to your doctor, they're thinking of what we call a glucose PET scan, or FDG. Prostate cancer does not use that much sugar. Glucose is sugar. It feeds on testosterone, right? And so the standard PET scans, actually Medicare came out years ago and basically said stop using them because it's not that they don't work at all, but they don't work well. But the whole concept of the technology is you inject something that emits radiation, little tiny bits of radiation therapy, and it can be measured in this scanner. And when you put this all together, it reconstructs an image and tells you where the cancer is. And there are some limitations that I'll get to. But it's about an hour-long test. You know, like it's similar, you could think of as a bone scan, but you get a little injection, about an hour, you get the scan. And this is the improvement. These are the same patient. So on the left is our standard of care, what I still have ordered, even this past week, a bone scan, and it shows some spine metastasis in this patient's spine here. But when you get a PSMA PET scan, it does show those same lesions, but all those little dots, let me see here, all these dots, these are lymph nodes, and some of these are bone lesions, that those are also cancer spots that we had no idea existed here. Now, there's other things lighting up. These are the patient's kidneys. These are the salivary glands. So there are other structures that light up normally. Doesn't mean it's cancerous, but it provides a level of resolution we never had. And so the US is catching up, but what's amazing is that like India, which most people would not say India is at the forefront of cancer care, they've been routinely using PSMA PET for 8 years, okay? Israel, standard of care. Australia, people joke, they say every street corner. Every guy, you know, it's like, it's, you know, liquid there. Everybody's getting one. But this year was the first FDA approval, and there'll be a couple more that may come this year or next year from other companies, to where now it's nationally approved in the United States. But like any new drug, imaging agent. As you know, it doesn't mean instantly access is everywhere, payers are going to pay, etc. But there is rapid progress. Thankfully, to what we call the NCCN guidelines, that are national guidelines that payers look to help guide them what they should and shouldn't pay for to some degree. They fortunately were very proactive and had it ready, that it's already in our national guidelines to support using PSMA PET. So we have the FDA approval and that guideline approval. The indications for it, as of right now, are what they say when there's a concern for metastatic disease. Which makes sense in that if you already have metastatic disease, is there a benefit of knowing you might have more? That's up for debate. But if you think you have non-metastatic disease, where we're trying to do surgery or radiation potentially cure you, we definitely want to know with the best tools we have available to rule out that there's any obvious areas of spread. And so this is most commonly going to be used in men who are newly diagnosed, who have what we call high-risk prostate cancer. The Gleason score happens to be an 8 or higher, the PSA is over 20, or let's say you get the MRI and we think it's spread outside of the prostate gland. And the most common indication is actually going to be for recurrent prostate cancer. You get surgery or radiation, and the PSA goes down, but it starts coming up. But they can't find where it is. This is the area that right now, and UH has already started this program. We've ordered over 100 scans since the FDA approval. Medicare, which we're pushing on hard, they right now are only covering indication 2. And variable coverage, which we're fighting with the private payers, but like anything, it takes patients' advocacy and constant pressure from the physicians to kind of get them up to speed. But having that guideline endorsement makes it a lot easier. So this is going to probably become a very routine thing for patients in these situations that they're getting. And so just, here's an example. These are both my patients that I've treated. So this is actually 5 years ago, obviously before I was here. I was a 58-year-old man, and he had a PSA that had risen to about 5, and his rectal exam was normal. His prostate MRI did show a concerning area for prostate cancer, and maybe it had spread outside the capsule, but the MRI couldn't definitely call it. And he got a fusion biopsy, what Dr. Ponsky was talking about, where they targeted that area, and it showed a Gleason score of 7, 4 plus 3. But the standard of care scans were normal, the bone scan, the CT scan. This happened to be someone who had the means and was, which I would say 99.9% of my patients did not do this. As I'll tell you in a moment, and he traveled all the way to Germany where this scan was originally developed. But with this information here, we would call him, intermediate or high risk, depending on how you want to call that MRI. And we would give him a very good prognosis for treatment. But he flew to Germany and got the PSMA PET scan, and this is his scan. And what it's showing you here is this is the bottom of his lumbar spine, and there's a metastasis right in his spine. And so despite the features, these standard features, the Gleason, the PSA, not striking, he actually has metastatic disease. So I can tell you, if I just radiated his prostate or he had it removed, 100% his PSA would go down and come right back up. And so what we ended up doing is we gave him what's called metastasis-directed therapy, which now there's a lot more trials that have been performed to support this. At that time, it was sort of out of the box. But we radiated with just a single treatment of radiation therapy his spine, as well as treating his prostate. And I still keep in touch with him 4 years or so later, and he remains disease-free. So it's not necessarily that this has to be, quote unquote, a death sentence, or that now he has incurable disease. But it means that we need to now have our evidence and our treatments catch up to now a new disease state, okay? Because previously we would have just basically never known about this. But this is not the same. The prognosis of this patient is vastly different than if they had a bone scan showing these areas of metastasis. So another example is, this is a gentleman, 62, his PSA, should we say, of 45. He had high-grade prostate cancer, and again, his bone scan and CT were normal. He had a lot of urinary symptoms, obstructive symptoms, felt, probably the best option for him was to have surgery. And so he underwent robotic radical prostatectomy, but at his first PSA, it was still 37. It should be, close to, if not undetectable by that point. And actually, by 12 weeks, it had already risen. It's almost back to where it started. So he underwent a PSMA PET scan, and what you can see here, it's a little small, but he had one major area in his spine and his pelvic bones, and this did not show up on his CT or bone scan, had a significant amount of cancer in it. So no wonder that the majority of his cancer was not in his prostate, so his PSA barely changed. Now, does it mean doing surgery was the wrong thing? We don't really know, because now that we have this imaging, we have to figure out how do we best treat these patients, because at one point you don't want to do something that you'd say is futile, right? That if you know it's not going to be beneficial, but maybe surgery would have been reasonable, but we also needed to radiate these sites or give him systemic therapy. And so there's a lot of ongoing trials now trying to catch up to what is the best way to handle all this new information. And so there's a lot of clinical trials we do. Radiation oncologists are sort of the nerds of medicine. And so we run all these randomized trials. And so before PSMA PET scan, we would quote a guy if they had high-grade or high-risk prostate cancer, and we treated them with radiation and hormone therapy. About 80% of them would be disease-free 5 years later. Okay, it's not 100%, but for high risk, this is a good outcome, not what we want, but it's reasonable. But now with PSMA PET, and this is study actually, it came from India, where they 8 years ago got PSMA PETs on all the guys and said, if you have no evidence of metastatic disease, we're going to treat you with radiation and hormone therapy. And now their 5-year disease-free rate is almost 95%. Why is that? What do you guys think? The treatments are identical. Why do you think their quote-unquote cure rate is so much better now? There you go. Because here, there's a subset of guys that there's cancer we weren't even treating. And here, you've not removed every guy, but you've put those men into the appropriate bucket of having cancer outside of the prostate gland. And so with this changes a lot. Because for years, we're talking about with high-risk disease, how do we intensify it? There's trials of adding all sorts of drugs to surgery. There's trials of adding all sorts of drugs to radiation. But now the trials going on are, how do we de-intensify therapy? If we're at 95% for our most aggressive localized prostate cancer, do we need 2 years of hormone therapy? So there's trials going on with 6 months, 12 months. Do we need to add these other drugs on to surgery or post-operative radiation? There's a lot of questions we have to still answer. And this is exactly what Dr. Ponsky was saying. So no scan can see anything smaller than the human eye can see. So when we look at a scan, fundamentally, there's little things in your body, blood vessels, lymph nodes, a variety of things that are, they're a couple millimeters in size. There's no way for us to really appreciate anything smaller than probably about 2 millimeters and think of it differently than just, vessels running through the body. But furthermore, the actual technology of a PET scan, the way those positrons, the way they're formed, the technology can't even allow the resolution below 2 millimeters, which is still millions of cancer cells. So one of the dangers that is happening whenever you have new technology is some patients or physicians will say, oh, the PET scan's negative. but the PSA is still rising, there is cancer there, you just can't see it. So, you know, where we are, and I think already, and we have some great work led by, you know, now it's great being part of this team here, some just phenomenal work with changing the way we even view the pathology images. No longer are we, I think, going to be talking about over these next years, we'll be hearing a lot less about Gleason, and we'll be hearing a lot more about how aggressive your tumor is in a, you know, AI-driven manner that extracts information far beyond just looking at those patterns. Because again, we've restricted our minds to this brilliant guy in the 1950s to tell us, here's the spectrum of prostate cancer, and clearly it's not good enough. But in combination with all this information, you know, this is one of Google's products, where they literally have been able to take these types of images and through artificial intelligence predict, you know, this is what their algorithm predicts, this is actually what the individual looked like. We're getting closer to actually seeing exactly what each individual patient has. We're not perfect, but we've been operating for decades closer to this, right? There was no MRI, there was no PET, there was various variability in how things were read. Outcomes were still, you know, good, but we need them to be phenomenal. So, thank you guys so much. It was a pleasure speaking to you all.
Okay, I'm putting you on the hot spot.
Go for it.
All right. So first thing I noticed on the imaging that we saw with the PSMA PET is, does it include the brain?
Yes, so one of the advantages of PET scans is that it scans the entire body, and it includes the brain. Now, we usually cut it off unless you specify around the knee or somewhere in that area, but it will scan, you know, the entire body.
So if we can get a PSMA PET scan paid for,
Yes.
which is always the stumbling block here, should we not do bone scans?
That is a phenomenal question. So in my opinion, and this is where, so I'm sitting on what we call the ASCO, the American Society of Cancer organization, is right now, countries that have had this for a while, bone scans are gone. This has been shown and studied to find 99.9% of anything a bone scan can find, plus everything else. But some of the proposals, and this is largely from insurance payers to try to slow down its adoption, in my opinion, is they say get a CT and bone scan, and if negative, then you can get a PET. If positive, you already have mets, you know, it's already spread, you don't need it. It's very myopic, and I think in most cancers in the human body, head and neck cancer, lung cancer, lymphoma, they for years already have their version of their PET scan, and I think it's just a matter of time that I hope that bone scan goes away, and we use PSMA PET, or there'll be others. There's a lot, and you know, if you get into the weeds, there's about 5 different types of this PET scan. They're all probably about the same, but yes, that's where I would like to see it, but I have a feeling we're going to play the game with insurance companies where we say, we got to get you a bone scan. If it's negative, then we can get the PET scan. So.
Yeah. Dr. Ponsky, do you have anything to add to that? Do you?
Look, I just think, I think I agree with everything Dr. Spratt said. I think it's a very exciting time. And for those sitting in this room who are at different stages of concern about prostate cancer, I think this should energize you, this should excite you, that we are seeing some major developments in the ability to treat smaller volume of disease than we have been before, identify it and then target it and treat it, even if it's outside the prostate. And so for years, coming to these meetings, been asked about what's coming down the pike for patients with disease outside the prostate. And I think you're starting to see this now. We've seen it in other diseases, and now we're starting to see it in prostate cancer. So I think we should be extremely excited about what we're seeing now. That's here in reality, not just in the laboratory, but there's a lot more coming down the pike. So I think this is encouraging.
Yeah, for sure. This patient wrote, after 25 years after radical prostatectomy and salvage radiation, his PSA is 0.66. Would he be a good candidate for a PSMA test?
Yeah, I mean, with assuming, so if it's just been staying at 0.6, you're on no therapy, and it's just sort of, we call it indolent. If it's staying like that and you're decades past treatment, I don't know if you need to look for a problem if you're feeling fine and the PSA is not rising. Now, if you're on therapy, let's say you're on hormone therapy and that's sort of where it's holding at, I would say absolutely I would get one of these scans, because the potential is we could then, most commonly, but you can surgically remove it, most commonly if we can find where that area that's making the PSA, we can do focal, very short course, like I said, just a couple treatments of radiation therapy, and often, not always, but often, get that PSA to drop, sometimes to undetectable. So yeah, I think it really just depends. Does it need to be looked at? In the sense, if it's 20 years and not changing, you probably got bigger things to worry about. Keep your heart healthy. But if it's something that you're actively under therapy or that PSA is rising, yes, I would get I think that PET scan is very reasonable.
And what's the washout from receiving Lupron or Eligard till you can do a PET scan and get accurate results?
So if you have, let's say, newly diagnosed disease, you should get the PET scan before you start any of the testosterone suppressing agents. However, if you have, let's say you're on hormone therapy and your PSA is rising or detectable, the PET scan still works. Okay, so there's sort of two differences. We call that hormone sensitive disease, meaning that if you're newly diagnosed, you lower your testosterone, it's going to essentially make the PET scan quiet. But if the PSA is rising while on hormone therapy, we call that castrate-resistant disease, and it will still light up on the PET scan.
Yeah. Okay, you mentioned stereotactic treatment for that patient you had. So a lot of people are going to ask, well, how many lesions is too many? Or who would be the right person in that metastatic setting to get that treatment with success?
Yeah. So success is defined in many ways. Typically for patients who have metastatic disease, I usually say if it's seen by just the PET scan, I say there's two forms of success. The one that is possible but not common, most trials, if you've got, let's say, 3 or 4 spots on the PET scan of metastases, about 30% of them we believe we can cure, which is something we never thought possible. But probably about 50%, so we'll call that another 50%, we improve their quality/quantity of life, meaning that, let's say you've got, for simple, let's not call it 1 billion cells, let's say you got 100 cancer cells in your body, and the radiation doesn't cure you, but it gets you down to 90. Or let's say it kills 90, you're down to 10. Or maybe you're down to 1, but it didn't cure you. It will take usually years to get back to that 100. And so it will delay you needing to switch to a new therapy. So a common example is a man has surgery or radiation, the PSA goes down, comes up, we get a PET scan, we target those spots with radiation therapy, their PSA goes down, may come up again, but maybe it's years later, but they never needed to be on hormone therapy during that time. So we call that hormone therapy-free survival, meaning that you got 5 treatments, kind of inconvenient, but you lived your life and you can repeat that. So how many lesions? That's an area of debate. There are trials right now treating up to 10 spots. I would say most of the studies are 5 or fewer spots. And it's up to the individual. If you go to prostate specialists, radiation oncology specialists, they'll probably be comfortable treating more areas. Then a generalist may only want to treat 1 or 2, or sometimes none. So that's really trying to find someone that has familiarity in using the PET scan with a multidisciplinary team and targeting those areas. I've had patients who have gone through 3 different rounds of, we call this metastasis-directed therapy. So we treat it, PSA goes down for a year or 2, comes up, and we repeat, and we keep them off chemo and hormone therapy. But it really has to be individualized. So we often are having these conversations at our tumor board with medical oncology, urology.
Good. I don't know how many people are in the audience that are on active surveillance or looking for treatments options. But oftentimes I have patients that I see that say right away, I want seeds. So, and could you just have a few statements about that? And also to educate the group on the OAR spacer technology, because I think this is awesome.
Yeah.
So we just have a few minutes until our break, but I'd love to just hear a few words.
So it's interesting. Cleveland, more than anywhere that I've traveled in the world, loves seeds. Between the Cleveland Clinic and UH, there is something, and again, I don't know if it's history, but that's an internal type. We call it brachytherapy, where it's kind of a mini surgical procedure. They put about 80 seeds into the prostate. They're radioactive, and depending on the type you use, they're radioactive for almost up to 9 months. Worldwide, the use of seeds has decreased substantially because one of the main benefits of seeds, they're a great treatment, is simply, it's very convenient. Compared to when you used to be 45 treatments or so of radiation, that is I don't know how I would go through that in my day. So the seeds was a very accurate and convenient way. Especially when 30 years ago, the radiation I just told you was just blasting through people's bodies. Now, the vast majority of my patients, I do just 5 treatments of radiation. It's that stereotactic radiation. And with what Sue's talking about, this rectal spacer, the company, it's called Space OAR. It's a hydrogel spacer for, not all men are candidates, but it's a gel that we collaborate with urology very closely. And they place the gel. It's just one needle goes in, transperineal, so that's skin between the anus and scrotum, and they inject 2 liquids, and when they touch, it's kind of like epoxy, it forms a little gel. And it pushes about 1 centimeter of space between the prostate and the rectum. And it got FDA approved about 4 years ago because it showed in that trial 0% of men had any mild, moderate, or severe rectal side effects. I'll never say anything is 0%, but it's a very, very low rate. I've probably treated over 500 patients with a rectal spacer, and so it's a less than 1% risk. So one of the biggest differences in side effects between surgery and radiation that's a negative for radiation historically is there was a higher rate of rectal bleeding. A good surgeon's almost 0%. Now that's, I would say, very similar when done correctly. So seeds are a good treatment. To get back to that, I think that many people have started moving away, but there are some patients that level of convenience, it's just one and done, kind of like a surgery, they like.
Thank you. Good call.
All right.
Thank you.
Thank you. Thanks, Sue.
I just wanted to